Hello and welcome to this edition of Rural Doctors. I'm Jerry Gannon. Thanks for your company. 2008 saw two new pieces of legislation in Western Australia that could affect you and your practice. The Medical Practitioners Act 2008 and the Children and Community Services Amendment Reporting of Sexual Abuse of Children Act. So we thought it was time to revisit medical legal issues. We'll get an overview of mandatory reporting of child sexual abuse from Dr. Geraldine Goh from Princess Margaret Hospital's Child Protection Unit. And later in the programme, we'll hear from Dr. Stephen Langford and Dr. Angela O'Connell with tips for preparing a patient for air transport. But right now, let me introduce our studio guests. And once again, we warmly welcome back, after a long absence, Dr. Peter Maguire. Welcome back, Peter.
Thanks, Jerry.
And to answer his probing questions, we're very pleased to once again be joined by Dr. David Watson. Dr. Watson has been a member of the MDA Council for 23 years and was president until last November. A significant amount of his practice includes medico-legal issues, and he's been teaching in medical schools and general practice for over 35 years. Welcome back to the programme, David.
Thanks, Jerry.
Now, I guess, Peter, as a GP and doctor, you'd be keeping very handy the number of your medical insurers, such as MDA.
Well, I don't have to ring it too often, Jerry, but medico-legal issues are always on the GP's mind these days, so it's nice to have you back, David. I thought we might start with some general questions about medico-legal risks and matters, and I guess what to report and when to report is probably a good place to start.
Okay. I think if you ask yourself that question, should I report something, the answer is yes. One of the things that we do not mind at all is members reporting things that have concerned them in their practice. Most of them will progress no further than that. In the event that any of our members have a lot of files, incident reports are excluded from any review. We don't punish the good reporters. We do punish people that don't report.
So it's better to report?
Absolutely.
Okay, well, that's good to know. Some of the things that I guess are the common things that get reported or cause or the substance for claims, I guess, are things like failure to diagnose. Can you talk a bit about where the traps are in failure to diagnose and what the developments are?
It's still one of our commonest group of claims, failure to diagnose. It's changing a bit. It used to be mainly cancer. One of the things that's emerging now is failure to diagnose acute coronary events. And here I have a great deal of sympathy for people in general practice because particularly in the metropolitan area, we've got these large funnels called emergency departments that funnel patients into them. They're backed by cardiology departments, but the patients don't get there. If they haven't got a troponin rise and their ECG looks all right, they get sent back out to general practice. And the best you can do in general practice then to investigate their chest pain is probably a stress test. Otherwise, you've got to go back to a cardiologist, and we've had several claims in that respect. The real issue still, though, is basic medicine. Good history, good physical examination, sensible use of a combination of the laboratory and your head.
Well, certainly when I was a medical student or a young doctor, the message was if you do those things, if you take a good history and examine the patient and do the right tests, even if you get the answer wrong, you're reasonably safe. But that seems to have changed? Or?
I don't think so. The critical thing that lets people down is not documenting what they're doing. And it's still absolutely crucial to any successful defence or even evaluation of an incident that there's good documentation. And, that's an absolute given.
I wonder if computer notes are improving this or making it worse. I see some computer notes that are pretty scanty.
Computer notes worry me a great deal. We see them a lot. In my own practice, I have patients coming in complaining that they can't talk to their GP anymore because all they do is talk to the bald head and the head is down over the keyboard. I've seen some dreadful notes, and handwritten notes still remain pretty good, but it's a question of time management. And I think a lot of people have not adapted to using a computer at the chair side in general practice. And it is an issue in the literature as well. It's not just our experience.
So it might take a generation or two until the younger doctors with computer skills get through to practice.
But it's all changing. It is all changing.
But on the question of computer notes, because computers are central to everything that we do now, and computers are tools that doctors have taken to, with alacrity, are you suggesting that there's a need for a different style of writing notes as opposed to the long-handed, almost indecipherable notes that many doctors would have written on paper?
Well, Jerry, we've got nowhere near exploiting the computer for things like clinical decision support. There's a lot of stuff out there that allows people to make decisions about clinical care against accepted standards and guidelines. We're not using that very much at all. Much of what happens in general practice with computers is just about trying to substitute a keyboard for a pen. And when I get a letter that lists the medications, usually it's a list of prescriptions written on the program, not necessarily what the patient's taking. So there's a lot of pitfalls in it. And one of the interesting things that's happening in the US that's not widely known here is that in the stimulus packages announced by the new president recently, there was a large amount of money set aside for getting computers into medical practice by 2010. Now currently the take-up is about 4%. So it's a huge task. The take-up in this country outside general practice is about the same. General practice has gone a long way further than specialist practice.
Absolutely.
So in a nutshell, David, what's your advice to doctors when taking notes on computers, when writing histories and the like on computers?
Well, I think what I have taught students for 30 plus years is you've got to learn the habit of listening and only take down notes when you're taking the history of facts, like drug doses or whatever it might be. But a lot of the history you have to listen to and then reassemble it later on, because the patient won't necessarily give it to you in a way that is useful to you. You do have to whirl it around in your head and then put it down. But by doing that, you're looking at the patient, you're not looking at the keyboard. That's the thing the patients find difficult.
Yes, but I guess it does raise that, and it does impact on the time management aspect that you were mentioning before. That it takes a little time between consults then to do that, which is.
And I'm conscious of the changing pattern of consultations in general practice. I mean, the time pressures on GPs are far greater than they are on me. I mean, I'm a consultant physician. I've got time.
What about audio notes, using a tape recorder to?
It's an interesting thing. You've got to declare it. I've had the experience of doing it a number of times, and it's surprising how quickly you forget it's on. So you still get good notes, but then of course you've got to transcribe it.
Yes,
and that's an issue.
And in terms of medico-legal issues, does that audio record have to be maintained as an audio record? Does it become part of the medico-legal process? Well,
some years ago, a number of people in particularly surgical disciplines, and especially plastic surgery, particularly where cosmetic surgery was involved, were actually audio taping consults. They'd give the patient one and keep one for themselves. The problems are making sure the tapes are secure. These days it ought to go on to disc, not onto tape. But provided you can show that it is secure and not capable of being tampered, and all that work's been done, it's all right, medico-legally.
Another interesting area which I guess computers play a part in is follow-up and recall. And it seems that perhaps a higher standard is expected there as well. And I know some of the cases that come to you are about follow-up or failure to follow up abnormal results or failure to communicate abnormal results to another doctor. Is that something that you see more of now?
I don't know that we see more of it. Let me tackle it in a couple of parts. The first difficult one is the GP who's seeing a patient that's not part of his practice, but let's say for a medical for the railways, and the patient's hypertensive. There's an absolute obligation to convey that to the patient's treating doctor, quite separate from what you do with the medical itself. And we've had a couple of claims in that regard. The best known ones, because there have been claims about them, have been failure to follow up on things like pap smears.
Yes.
Now, there is to a degree, a safety device there, because the pathology people also follow up on it. But I think what we really need to do in our own practice is have a system whereby in general practice, patients should come back for results. I know that's something that causes problems, but it's best that they're not given out over the phone. That there is a system of tracking to make sure that the patient has got the results, either face-to-face or on the phone. One of the things we have seen a couple of times is practices not actually having contact details correct, and it is absolutely essential that contact details are correct and checked again regularly. Patient hasn't been to the practice for 3 months, check it again. If they're regulars coming in every week, you don't have to. But
sure.
And of course, there are different issues in some parts of the state, like the coastal strip, where you've got a lot of itinerant people.
Yes, I did a locum once in Kalbarri, and
It's
not many regulars. There's an awful lot of transits.
Yeah.
And
if you've got abnormal
problem.
results, the question that I get asked is, what is a reasonable attempt to contact people? I think 2 documented phone calls is probably the best you can do. It depends a little bit on the result. The next step up the ladder would be a registered letter, provided you've got the address right.
Yeah.
Now, provided you've done that and it's well documented, that's the best you can do. I've been involved in a project some years ago trying to track patients on behalf of all the St John of God hospitals in WA who'd had blood transfusions before 1990 of donors subsequently shown to be Hep C positive. And even with all the resources of the health department and getting access to voter registration and the lot, it's almost impossible. If people don't want to be tracked down, they won't be.
Yeah, okay. And I suppose the doctors working in Aboriginal medical services in rural areas probably have a degree of difficulty there that's beyond the rest of us, I guess. But,
yeah, I'm sure they do.
Yeah.
A related one are people like truck drivers and people flying in and flying out who may have medical practitioners at either end, and that can be a problem as well.
Yes, because sometimes you're not actually sure who the treating doctor is. I mean, if someone's half the time in Europe and half the time here, am I the doctor or is the European doctor?
That's right.
Who's responsible?
Yeah.
Where does it end?
In the end, it ends with the person that ordered the test.
Yes. There's been, I guess, another issue that recently that's cropped up. I think it's follow-up of after hours abnormal results, which is probably less of a problem in the country actually than it is in the city, where doctors work 9 to 5 a lot of the time. But abnormal results that come back to the pathology company at 9 o'clock at night, and they've got to find someone. They've got to find somewhere to contact the doctor.
There are a couple of things
someone.
about that. There's the follow-up of after-hours results, but there's the follow-up within a general practice itself of results of tests ordered by someone who may only be there for 1 or 2 sessions a week.
Yes. That's
Who
a big
carries
issue,
that responsibility?
yes.
It is a big issue, and I've certainly seen a couple of important matters slip through the holes in the floor, and I think every practice has to make their own decisions about that as to how they handle the issue.
Just going back to the question of the efforts to contact a patient, you mentioned a documented phone call. One, where do you document that phone call? On their file?
On their file.
Do you have it witnessed or anything like that?
No, I think if it's being done by one of the receptionists, often practices have a system of recording telephone calls,
Right.
which is separate from the file. But most of those systems have a tear-off sheet that probably should go into the file. So there's one record in the pad and the tear-off sheet goes into the file.
And the registered letter, that letter is simply to summon them to the practice to pick up their results, as opposed to sending them the results?
Yeah, I would still think it better, particularly with important things, that it's a face-to-face meeting.
Then GPs do a lot of work over the phone, and I don't think we all would record all phone calls, but I suspect that will become an expected standard.
I suppose with
And email now, of course, with
Yeah.
computers. I certainly email patients with results occasionally when they give me their email address, and then copy the email into the electronic record. But I suppose that's I guess there are pitfalls in that in terms of confidentiality and security.
Yeah, I worry just a little bit
Yeah.
about emails.
Yeah.
And, for example, I have stopped emailing reports into MDA.
Right.
I now do them all like I do any other medico-legal report and send them by snail mail or deliver them myself. I don't. It's because we haven't solved the problem of encrypting important information. And the problem with encryption is everyone's got to be using the same system, and that partly gets behind why you're doing it.
But if one of Peter's clients or patients or any doctor's patients where the results are all okay, where there's no issue, there really wouldn't be a problem in either passing them over the telephone or on email, but where there is a potential for an adverse outcome, that's really where you're insisting at the face-to-face.
That's right. Yeah. And, I mean, it's not unusual for me to arrange some tests on someone. I did it twice today. And I've said, because I expect I'll be all right, I'll give you a call, which I do. And I usually then confirm it in writing. What I normally do is write to the referring doctor and copy the letter to the patient.
Sure.
Peter started talking there earlier about misdiagnosis as being the potential for litigation. What sort of rate of successful actions against doctors have there been for misdiagnosis?
It's very low.
Very low.
It's extremely low. Well, usually it's because the diagnosis has been made in the face of such overwhelming contrary evidence.
Right.
It almost becomes a question of competence.
Yes. Another area that's been, I think, quite a lot in the news, I suppose, is sexual misconduct allegations. And I guess false allegations are probably just as damaging to the doctor as if the doctor was guilty. Have you any tips about how to avoid being accused of sexual misconduct in practice? And it's hard for GPs, I
It's
guess.
very hard for GPs. An awful lot of people in general practice and specialist practice have moved away from the sorts of consultations and, more importantly, examinations where that's likely to occur. One of the things that I do in my own practice, or in fact my secretary does, which is not necessarily easy in general practice, is we invite patients to come with someone else of their own choosing, even to a first consultation, let alone subsequently. The third protection is usually fairly easy in general practice, is having a good relationship with your patients. But if you do have to do examinations where that's likely to occur, it always raises the question of having a chaperone. An issue of some controversy in general practice. But if you've got any doubts, you're better off having someone there.
And the role of the chaperone specifically in these cases?
Well, it ideally should be, if you've got a practice nurse, that's the ideal person. I mean, I have a receptionist. I would never have her sit in when I'm doing an examination. So I just don't do them. The sorts of things that Peter's talking about, in fact, are less to do with examinations and more to do with getting a sense about a consultation that doesn't feel right.
Right.
And also, I now tell students, I was taught every examination had to include a rectal examination. Well, if someone comes in with an ingrown toenail, that's extremely difficult to sell.
It is, yes.
But you take the case of many of our doctors who are single operators, working flat chat, stressed to the max, resources are very skinny.
Maybe no practice nurse.
No practice nurse, exactly, which is often the case. What sort of chaperone would you look for in that kind of situation?
Well, if you're in the situation of having to do, let's say, a vaginal examination, and it's possible to put it off, that's what I do. If you're feeling uneasy, and let's say it's early evening and you're by yourself in the practice, everyone else has gone home, I'd put it off and bring them back another time.
With their own chaperone?
Well, preferably with someone else.
Yeah.
I guess when we're saying vaginal examination, we're really talking the different gender. I guess there's a lot of female
Correct.
GPs who would obviously not use a chaperone.
It wouldn't be an issue for
But
them.
I guess we're talking about male GPs.
Yeah.
Certainly in my younger days, I didn't have a practice nurse, and I would have, and I knew my patients well, and I would often not have a chaperone present. But I think your comment about the gut feeling thing is appropriate, and if I had that uneasy feeling, then I wouldn't. I would make some excuse to delay.
And I think most people who've been in practice for 5 years or more are going to pick that sense up pretty early, and then you just have to listen to the vibes you're picking up and find a way of avoiding it.
Which brings us to the question of overseas trained doctors who may not be familiar with the culture and then may not pick up that vibe. Does that concern you at all, David?
That's where most of the difficulties have arisen
Right.
in the last 4 or 5 years. It's a cultural thing, not just about what's an appropriate examination, but also the way, particularly the way male doctors treat women. And we see it in hospitals as well. It's not confined to general practice.
And there are some of the language subtleties that come in as well. So that is a difficult call.
Yeah.
So how would you advise your IMG colleagues, who many of whom are watching?
Well, I work with a significant number in my hospital, and it takes us about a year to get them accustomed to the nuances. They all speak English. Most of them come from the subcontinent, but it takes, and I have an education role in the hospital, it takes me at least a year to be confident that they've got over most of those issues. And we're very careful about making sure that they don't get themselves into situations where they could
Well, we might pick up on this and other issues a bit later. We'll take a break right now and go on to something else. Dr. Geraldine Goh is a paediatrician working with Princess Margaret Hospital's Child Protection Unit and at Child Development Services in West Perth. Now, she's currently putting together a resource for GPs in response to the Children and Community Services Amendment Reporting of Sexual Abuse of Children Act, and she was kind enough to give us an overview of the Act and its implications for GPs.
Mandatory reporting legislation stipulates that doctors who have formed a reasonable belief that child sexual abuse has occurred or is occurring since the commencement of the legislation, or they should make a report. This legislation came into effect on the 1st of January 2009, and it extends to doctors, nurses, midwives, teachers and police officers. If the suspected abuse occurred prior to the 1st of January 2009, well, the doctor should still make a report, but there is no penalty if a report is not made. And depending on the setting, the doctor may then refer the child onto a paediatrician or a tertiary unit for further medical or forensic evaluation. And certainly in some cases, such as remote and rural communities, the local GP may be the only available doctor around, and it is important that that doctor recognizes that he or she still has a role in performing a medical assessment and possibly collecting some preliminary forensic specimens. And this can all be done in conjunction with tertiary advice. It's important to stress that it is not the doctor's role to investigate the abuse or to investigate whether the abuse has occurred or not. One does not need proof that sexual abuse has occurred in order to make a mandatory report, but simply a reasonable belief that it has or is occurring. A reasonable belief is usually made when you consider a number of variable and differing indicators that could be physical or behavioral, and that should be considered in context. However, it would be obvious if a child had come up and made a clear disclosure to you in a clinic setting, or if that child has made a disclosure to the parent or the carer. Some concerning physical signs and symptoms would include pain and bleeding around the genital and anal area, if one has made a diagnosis of a sexually transmittable disease, if a child has an out of proportion fear and anxiety about a particular person, unexplained fears, recurrent nightmares, if they suddenly give you the impression that they are required to keep secrets, if they are exhibiting any sexualized behaviors that are out of proportion to their age and development, And other internalizing behaviors such as tearfulness, anxiety symptoms, or externalizing behaviors such as anger and aggression, all these behavioral symptoms are all possible. But I might add that in some cases where abuse has occurred, some children may not even have any of these. In rural and remote country areas, anonymity can be very difficult, especially when you have established relationships with, the child's family or the alleged perpetrator's families. An alternative would be to refer the case onto a tertiary unit or pediatrician upon discussing the case with them. The Child Protection Unit at Princess Margaret Hospital is the tertiary unit for Western Australia, and we have a social worker and a doctor available to consult on cases during daytime hours and also after hours. I do need to say though that if you are the primary doctor that has formed the belief, then you should and still are required to make that report. The forms can be obtained and downloaded from the DCP website, and if you are linked to the Department of Health, they also have links onto DCP's mandatory reporting site. The form is really self-explanatory. It's really about filling in the gaps, and it's really clearly stated what needs to be filled in. Make sure that you have all the contact details of varying persons involved in the case, and also to just give succinct details on what the basis of your belief has been formed upon. It is a mandated report, so we are legally obliged to make a report, and as it stands, the penalties are up to $6,000 if one has not made a report. And if one hasn't followed up a verbal report with a written report, then the penalties could be up to $3,000. As part of the assessment or investigation process, reporters may be contacted by DCP officers or the police to obtain further information. The mandatory reporting service, upon receiving your report, will often churn back an acknowledgement receipt and also provide a feedback letter to the reporter advising the person of which district office has taken over the case of concern, and or if no further action was recommended. I think it is very important not to assume that once a mandatory report has been made, that action has been taken. And if you still believe that the child is still at risk, then you should contact DCP or crisis care to pursue those concerns that you have made in your report. If you are sharing information with others in the course of your work role for the purpose of seeking and protecting children from harm or abuse, then the law protects you when you do that. Under Section 29 of the Child and Community Children's Act, the reporter is protected from criminal and civil liability and is deemed not to have breached any duty of confidentiality or acted unprofessionally when the report is made in good faith. Presently, we are in the finishing stages of producing an educational CD-ROM, and that is a novel and accessible tool for health professionals who wish to learn more about this area of medicine. It will cover many aspects of child sexual abuse, including epidemiology, definitions, the doctor's role, matters of consent and confidentiality, and we hope to have this available towards the latter part of this Yeah, and anyone who is interested in it should make contact and leave their contact details with us at the Child Protection Unit.
And a big thank you to Dr. Geraldine Goh from Princess Margaret Hospital. And as soon as her CD is available, we'll provide information about how to obtain it on the Rural Health West website. Now, David, mandatory reporting, is this something that doctors should be worried about as opposed to being thoroughly conversant with?
Well, I don't know they need to be worried about it. It's come in all around Australia. What we're doing here is very little different from elsewhere in the country. Through our offices in the other states, we've had virtually no inquiries at all. I expect the same thing will happen here. My biggest concern, I guess, is whether Child Protection have got the resources to do it.
And that is a genuine concern. Nonetheless, do you feel that doctors are feeling that perhaps this is an inordinate and unwanted and unnecessary pressure on them, given that most doctors are ethically bound anyway to report anything that they think is suspicious?
Well, I think we're always a bit leery about legislation that compels us to do things. It's not new, I might say, because we are compelled to report certain infections. Cancer has been a notifiable disease here for 15 years. But it is another burden on general practice particularly, and potentially in rural general practice, because of the different relationship that frequently exists between a GP in a small country town and the community that he or she serves. It may not be possible for a report to remain confidential, and I think that's a potential difficulty. My advice to anyone who's got concerns is they ought to get advice from wherever they like to get advice from, but not the department. Either their medical insurer or the college or the AMA.
You've been heavily involved in watching this legislation go through, and presumably you've had some input into it.
Some, but not a lot. It was largely taken from what was happening interstate.
Right.
There was a lot of discussion, more with the AMA than there was with us.
But the MDA and other medical insurers would have access to readily available advice for doctors?
Oh yes. And I'd encourage anyone to make sure that they get that advice before they do anything.
One of the areas that some of my colleagues have raised concern about is how we deal with underage sexual activity, which technically is illegal. And I understand there were some moves to toughen the reporting requirements up in regard to that. But as I understand it, if, for example, a young girl of 14 or 15 has a boyfriend of 16 or 17, and they seem to be, competent people, that doesn't necessarily equate to sexual abuse. But if it was a 15-year-old girl and a 25 or 30-year-old guy, that would be potentially reportable. Have you got any guidance in regard to underage sexual activity and how that should be approached?
It's delightfully vague.
Yeah.
Because in theory, the scenario you're talking about probably should be reported, but the reality is that most times I think it wouldn't be. And under the provisions of the mandatory reporting proposals, you've got to have reasonable suspicion, but what is reasonable suspicion is delightfully vague in the definition. And no one is going to successfully legislate to stop sexual activity in people underage.
Sure.
So it's just not going to work.
And as you say, the resources for following it up, I guess the areas where this is probably most difficult are in the northwest with Aboriginal communities where, unfortunately, underage sexual activity is very common.
Yeah.
But that's probably where the resources are least available to follow up.
That's right. And, we've heard about the epidemic of sexually transmitted infections up there, and it's hard to imagine that is anything but sexual abuse.
Absolutely. Then we might move on to the Medical Practitioners Act 2008. Is there anything new in that we need to know about? Or?
Well, firstly, it replaced the oldest act in the statute book, which was passed in 1898, if my memory is correct. The one thing that's in there that people do need to be aware of is that it provides that we should advise the board of potentially impaired colleagues. And that's legislation was first put up here. It's now being looked at in other states. We think it's been softened for the national registration, and any proposals about national registration will affect our Act as well. So people need to be aware that there is that obligation. It's, again, like the mandatory reporting of child sexual abuse, delightfully vague in the definitions.
So much of this, both of these acts, that issue about reporting of impaired colleagues, we're really never going to know if these actually work until there's a test case.
Correct.
Now, I also noticed that there's a fine of $6,000 for failing to make a report, and a person, in this case presumably a doctor, can be prosecuted for up to 3 years after the event, and even after that at the discretion of the Attorney General. That's enormous pressure on a doctor to maintain records and notes for that time and recall as to what exactly went on in their heads at the time.
Well, it goes back to something I said in the first half, and that is having good documents. I mean, our advice to people with respect to their notes is if they're dealing with children, they have to keep them for 25 years.
Yeah.
Now, that's also advice that a lot of my GP colleagues don't like, but that's the reality.
I have heard recently of practices who cull their notes after a relatively short time. So that's a bad idea.
Very bad idea.
But there's no real excuse for that anymore, Peter, because you've got many companies who are doing records management and who actually specialise in the health area. So your notes can be archived onto electronic media.
Yeah.
Yes.
So
yeah.
And all the problems about having notes stored on disk and stuff in ways that they can't be tampered with so that they're considered to be secure. Because one of the worst things about written notes is the potential for people to go back and retrospectively
add a few bits
bits to make them look better.
That's right.
Yes, yeah.
Now again, looking at single doctor practices, say in the wheat belt or wherever, where doctors often come and go, where a doctor, say, who may be here from England or the subcontinent for a short period of time, maybe 2 or 3 years.
Even 2 or 3 months.
Or 2 or 3 months. That's exactly
Some
right.
practices are just like them run.
And 3 years afterwards, there's an action against that doctor who's long since fled. Where does the responsibility lie?
Well, we've already had that.
By fled,
situation.
I don't mean to say that they've actually absconded.
No.
I mean they've left the jurisdiction.
No. And what complicates that is how the practice is set up, because a significant number of those practices are actually owned by the Shire.
That's right.
So the notes actually are the property of the Shire. So they should stay there, so that at least they're accessible for someone, and it's usually going to be an organisation such as MDA, because we cover most of those doctors. So at least we can access the notes. And we do try and access the doctors if they've gone back to the UK or wherever.
Yep.
But in this case, do you cover the practice or the doctor?
No, we're covering the doctor, even after they've gone.
Right, okay.
It can be quite a bit of work.
Well, it sounds like it. Now, from your experience, because I guess a lot of shires, the relationship between a shire and a doctor is not always smooth.
True.
Based on the fact that shires don't know much about what goes on inside a medical practice. Is there a need to educate shires a bit more on their responsibility?
Well, I suspect they know a lot more than we think they might.
Okay.
And a lot of them have had to learn the hard way because there have been difficulties. But they can get advice. They can certainly get advice from us, even though they're not members. Their doctors may be members, and they usually are. The AMA will often provide advice as well, as will the health department. And so there's plenty of ways of accessing advice. The local government people themselves have been through this. The country shires have all been through it, and they've been sharing information for quite a long time. So I think there's a degree of sophistication if you talk to some of the older hands in rural shires.
I guess that leads nicely into medico-legal reports, which I guess every doctor ends up writing a variety of reports for insurers and all and sundry. And some of us end up writing reports for MDA or lawyers. What are some of the tips about what's a good report and how not to look embarrassed in court?
Okay, let's divide them into two unequal groups. the first and more common one in general practice is you're writing a report because you're the treating doctor.
Yes.
So you're not an expert. You don't have to give an expert opinion. What you have to do is state the facts, how the patient presented, what you found, what tests you did, what treatment you ordered, what referrals you made, and what happened in the follow-up. And that's pretty well it. You're not going to be asked to comment on other expert reports or anything like that. It's a pretty straightforward thing.
So the lawyers usually ask you about prognosis.
Well, I was just about to say that. The lawyer, particularly say in a coronial inquiry.
Or a case.
Well, I still consider that part of what you do as a GP, because you are talking about prognosis.
Yes.
You are going to talk to a patient about what you think is likely to happen with this.
Yes.
And often you'll get a specialist opinion to try and flesh that out, because you may not know the answer. So that's a relatively straightforward thing to do. It's the expert report that's much more difficult, and there the standard is different, not only of the report, but of what happens in court if you get there. And let's be clear that you won't often get there. Most of these things never get to court. There you have to not only assess the patient if you're asked to see the patient, but certainly assess a lot of documents. And you will be asked to express opinions, sometimes of other experts' reports, and your assessment of the case and what it's made up of. There, you're well advised to make sure that if you are expressing views about it, you do refer to the literature and standards and guidelines. So it's not just your own opinion. Where people usually trip up is where they express an opinion that may not be backed up by other experts and the literature. Now, the biggest difficulty that I find in general practice is finding GP experts, because general practice is a different discipline to specialist practice. And if we're dealing, say, with a GP obstetrician, I think we must make certain that we're getting opinions from other GP obstetricians about a lot of the management, if it's an obstetrics claim, even though we might still get specialist obstetric advice about some things. But the standards are different.
Yes, I think most GPs would applaud that stance, because I think over the years GPs have seen opinions which, from a specialist viewpoint, might make sense to the specialist, but are perhaps unrealistic in the world of general practice, or perhaps just don't reflect the standards of general practice in some way. I'd just like to touch on consent issues, which I think again perhaps has become a bit tougher as the years have gone by. One doctor asked about the consent for sterilisation and any special requirements there, but I've also seen doctors getting written consent for things that I would never have felt necessary in the past, like simple skin excisions or very minor procedures, like even flu vaccine, for instance, that actually get written consent. Is that overkill?
I don't know that it is, but let me put a piece of history on the table. Neil Blewett, when he was Minister for Health, you'd have to say was not beloved of the profession, particularly the troglodyte right. And on advice, when AIDS testing first became available, he made a public statement that every doctor testing a patient for AIDS should get consent. And there was an absolute riot, partly because he said it. But it was on good advice, because what he was actually saying was, this is not consent for treatment, this is consent to do anything. And it doesn't just apply to procedures. Now, I think if people have any doubt, then they're better off at least having a note in the file that they've discussed the reasons for the procedure, whether it's taking off skin lesions or whatever, and also discussed the potential complications.
And I guess that goes for medical treatments just as much as surgical ones. If someone's using a medication that's perhaps new or experimental.
Particularly if it's off-label.
Off-label, yes.
And we've had a number of claims that we've eventually settled for that reason, because there's been little or no discussion about potential side effects.
So there's still some patients who insist on taking quinine for their cramps.
Yep.
And I guess we've been warned time and time again of the risk of thrombocytopenia. And you can say no, but if I have occasionally said to people, explained the risks and said, well, on your head be it if you choose that. But But you'd want that documented pretty carefully.
I think if you just wrote that in the notes, that's all you need to do. It doesn't need to be signed off on.
No, sure.
So will there be any occasion where you would get a patient to sign consent, David?
Probably not, unless it was a formal procedure in theatre where you can't get in the front door without the consent form.
Right.
That's part of the process.
Yeah. And as for quinine, the best way to take quinine is in a gin and tonic.
Absolutely.
Yes. There was also a question about wills and dementia and competence and recording that, which is an issue that GPs quite often come across, being asked to witness either wills or powers of attorney for patients and their relatives. Have you any tips on that in that area?
Well, a couple of things. In general practice, it's a bit different because for a lot of people, they've got a longitudinal relationship with patients. And so the first thing that I'd be saying is anticipate in old grandpa that he's starting to lose his edge and make sure you've talked to him, preferably with his wife or daughter or someone else, about things like power of attorney. Saying that they ought to get that and wills sorted out now while he's still okay to do it.
Yes.
That will get by most of the problems that most people will see. The one that trips up, of course, is someone who becomes acutely ill or has a stroke or some other major metabolic problem, which then forces you down the guardianship board path, potentially, if it hasn't been sorted out. But I think much of it in general practice you can anticipate. The other point about wills, of course, is if we're witnessing it, we're only witnessing the patient's signature.
Sure.
We're not witnessing that they understand what they're signing. That's an entirely separate issue.
But we are asked sometimes to make a note about their competence at the time, I guess.
Well, I would always encourage, if it's a will, what I've tried to do is to make sure that the solicitor who's drawn it up is there.
Yes.
And then that gets by that problem. And most times that's the way I do it. Now, again, that's not necessarily practical advice in general practice.
Yeah, but sometimes it can be done. I guess even in rural areas, you've got your solicitor in town.
Usually it's a person in town.
Yes. Yeah.
So I think that's the safe way.
Thank you.
Good. He's got answers for all our questions tonight, which is the reason he's on the programme. Now, if you were at the recent Rural Health West annual conference, you might have seen Dr. Stephen Langford and Dr. Angela O'Connell from the Royal Flying Doctor Service with their patient air transport simulator. Dr. Olga Ward took the opportunity to jump into the simulator and asked them for tips and advice on preparing a patient for air transport and the issues that need to be considered.
Stephen, Angela, could you tell us a little bit about some of the common mistakes that are made or some of the pitfalls in transporting patients with the RFDS?
A common problem there is perhaps not calling early enough, in other words, as soon as you've identified that you need to move the patient. And that can be well and truly before there's a destination planned for the patient. It's just that there is quite a long lag time for us to get transport in motion. In Western Australia the distances are quite long and it does take a long time to get there, so the sooner we know about it the better.
What kind of information do you need when we're handing over a patient?
Okay, for people, just for simplicity I suppose, all referring locations have got a book of forms called the flight registration forms, and that's set out in almost a mirror image of the forms we use to collect the information over the telephone. So if people have that there in front of them, they'll find it easier to give the information to us. So if it's a desperate emergency, we may not need an awful lot of information to get the wheels in motion, and we might be able to get back to you afterwards to get some of the finer details about the state of the patient. But in general, we need to know the story of what's happened to the patient and their current status, so current set of observations, what you've already done for the patient and what you're planning to do. If you've already been given advice from a specialist service, for example, a toxicologist, what they've advised you to do, and you know, there may be situations where you've been advised, for example, to give a medication that you don't have access to, and we can start sourcing that to bring on the flight with us. But the earlier people call us, the sooner we can start getting all that sort of stuff in place in order to have it on the flight with us.
What we'd like to keep pushing is this calling us early and not having to organise a bed necessarily before they call us. I think there's a lot of time can be wasted ringing around getting a bed in at the tertiary hospital, and that half hour, an hour that might be spent, we could be on our way. So I think just getting back to that preparation, first thing is let us know that there's an evacuation, give us some accurate clinical details, and then if you want to go and refer the patient and get the bed sorted, that's great. But if you've got a really sick patient and you're absolutely flat out, you're handbagging them, trying to resuscitate them, we can actually organise a bed for you.
Could you talk a little bit about managing unstable psychiatric emergencies?
Well, we see a few pitfalls with acutely disturbed psych patients. I guess our perspective is obviously different to that of the doctor who's on the ground, but where we see problems is patients either being inadequately sedated, so they've referred them for air transport. We've discussed having some sedation prior to flight, and then we arrive and find them combative and totally out of control, and for air safety reasons we clearly can't carry those patients. The other problem is when country hospitals accidentally go the other way, and they've got a long period perhaps waiting for us. They sedate the patients over heavily and without adequate observation and monitoring. There have been some incidents of patients, aspirating respiratory arrest. So it's a very difficult and challenging area, but it's I think probably sedation is the key. There's some other administrative problems in terms of documentation and all that, but in the end that's not clinically relevant. It's just making sure we've got the right forms.
What about the extremely obese patient or the patients who are really tall?
Yes, well, not so much the extremely tall, they just tend to hang off the ends of the stretcher. But the obese patients, we need to know precisely as possible what the weight of the patient is, and that's for a number of reasons, primarily aviation, in that you can see it's a small aircraft. Pilots need to be able to do their calculations for weight and fuel balance. We need to send the right aircraft for that patient, so if we're not told that the patient weighs over 130 kilos, we turn up with the wrong aircraft, we won't be able to fly them anywhere. But patients in excess of 130 kilos we can still carry on, for example, the PC-12, this sort of aircraft. If they fit on the stretcher, that's great, there's no weight limit for the stretcher. We may need some extra assistance getting the patient in and out of the aircraft, so sometimes we have to call the fire brigade or the police in to help load and unload the patient. The patient doesn't fit on the stretcher, then we do have a means of, essentially we'll take the stretchers and their restraining systems out of the aircraft and strap the patient to the floor. Again, that's going to require a lot of assistance in terms of loading the patient on and off the aircraft. But it is doable. We need the opportunity to plan, so sometimes it takes a little bit longer to get going, but we've got to do it in a way that's safe for everyone else that's involved.
Sometimes patients have penetrating eye injuries or other kinds of penetrating injuries like abdominal stab wounds. Are there any special considerations that we should have when we're preparing those patients for transport?
I guess it depends on the location. So if you start with eyes, penetrating eye injury, we need to bear in mind that there may be air inside the eye, and we'll transport the patient with a sea level cabin in the aircraft so that we're not getting a raised pressure inside the eye. Penetrating chest essentially manages any other sort of chest trauma. They may need a chest drain put in because the actual source of where the penetration goes in may become a one-way valve, if you like, and put the patient at risk of a tension pneumothorax. Abdominal penetrating injuries, again, we might think about using a sea level cabin. We have to bear in mind that any time we decide that we want a sea level cabin, that the trip's going to take a lot longer, use a lot more fuel, and be in some instances a lot rougher. So we have a number of issues to balance there, because if you've got a C-spine injury that's you don't want the patient being tossed around in turbulence, but you've got another injury that you don't want to go to altitude with. You have to try and decide which bit's most important for that patient.
Stephen, are there any other pitfalls that you can think of?
Well, if we look at, say, one group, which is patients with acute cardiac conditions, coronary syndromes, I suppose we have a different perspective on patients because we see them being transported. And I guess the one area that we're mindful is not always managed well is thrombolysis, rapid thrombolysis. Most patients in the areas that we service are not going to get PCI in an appropriate time frame, so it's important that if the doctor diagnoses a STEMI that they undertake thrombolysis themselves. Now, there's plenty of avenues of advice. They can send an ECG to us and get advice from our doctors. They can fax it also to the coronary care unit and get advice. But giving it early, time is muscle. I think that's a really important message. Probably the other issue over the years we've had is a patient with an acute coronary syndrome or an infarct is a time bomb, and sending them out to the airport in just an ambulance with volunteers probably isn't good in terms of duty of care. They should always be accompanied by someone with the skills and knowledge to be able to defibrillate them or manage any emergency. And so we sort of follow a principle that once a person's in a health system or a health service or hospital, the level of care shouldn't diminish in any way. It should at least remain the same and increase all the way through the cycle till they get to definitive care.
My recall is that when I've had an unstable patient, often the RFDS doctor has arrived at the airstrip and the ambulance has picked them up and brought them back to our emergency department. We've stabilised the patient together and checked them out before they've gone.
If a patient's unstable or complex and needs lots of interventions, our staff will come in to the referring hospital and help sort them out. But for something like, say, an acute infarct we were talking about, they can readily be thrombolysed and brought out to the airport. They're not complicated. And in fact, there's some patients who might have really urgent, complex problems where you can't stabilise. And take, for example, a bleeding abdominal aortic aneurysm. There's nothing we can do. So if they're brought to the airport, we save about an hour and a half, and we get that patient to a tertiary hospital quicker, and we give them a better chance of a good outcome. Same goes for threatened preterm labour. It would be very rare and inappropriate for us to waste all this time coming into a hospital when the patient could be at the airstrip at the moment that we arrive, ready to go.
Communication's the key to success in all aspects of this, and it's very important for people not to just assume once they've made that phone call that that's all they need to do. They need to let us know about any changes in the patient's status, whether they've improved or gotten worse, because we've got a number of other patients in the system as well that we may need to perhaps put their patient up the rung if they've gotten worse, or we might be able to defer that flight and go and get someone who's sicker. Or in fact we might have embarked on a nurse-only flight and the patient's now sicker and we're requiring a doctor-accompanied flight, and we need that information because people need to be aware that not every single aircraft has got a doctor on board, and there's nothing worse than a nurse arriving to find the patient much sicker than expected and having to send it back to the hospital to turn around and come back and pick up a doctor. So that constant communication of changing status of the patient is really very important.
We have a very systematic, methodical way of obtaining clinical information. History, examination findings, interventions. And whilst some practitioners may think they're getting an interrogation, what we're trying to do is assemble all that information in one call, and on the basis of that we then decide the priority of their patient compared to maybe a dozen other patients we've got to do. So if they would just bear with us, if they follow the standard system on our referral forms, then all the information we ask is exactly what's on that form, and they'll be able to convey it very quickly to us. And then at the end we can have a discussion as to the urgency of the flight, and we can say, look, is it okay, we're probably not going to be there till this afternoon, and they can advocate for their patient and say, look, it needs to be earlier, and we can have a good sort of discussion, clinician to clinician.
Our thanks to Dr. Stephen Langford and Dr. Angela O'Connell. And if you'd like more information, the RFDS is about to release a booklet called Transporting Your Patient, which provides a comprehensive guide to patient air transfer. The booklet provides all the information you'll need to organise a transfer and prepare your patient, as well as tips for specific groups of patients, including trauma, burns, obstetrics, cardiac, neonates, and more. The booklet will be available soon through the medical department at RFDS on 9417 6300. So that'll be a handy booklet. So, David and Peter, any final thoughts, take-home messages?
Well, I think, Jerry, medical legal things worry doctors a lot, largely because they don't come in contact with it very much. And I'm not suggesting they should change their practice to get more familiar with it. But my take-home message would be, when in doubt, ask. And there's plenty of help, particularly through each and every one of us has a medical indemnity insurer because we're required to. They're always happy to provide advice.
That's what you pay your premium for.
That's right. It's just a phone call away.
Pete, any last words?
No, I think that's great advice. There have been some interesting tips tonight, but I think good. It still sounds like if you practice good, solid medicine, that you won't run into too much trouble with the legal profession. But I take the point. Ask.
Ask.
Definitely ask.
Good advice. Well, that's all we have time for tonight. Now, don't forget, if you'd like to review this program or any previous program, you can watch them online or download them as video or audio podcasts via the Rural Health West website at www.ruralhealthwest.com.au. We're back again on June 2nd with a program on trauma. So if you have any questions, please note them on your evaluation forms and return them to us as soon as possible. Thanks again to our panel tonight, Dr. David Watson and Dr. Peter Maguire, and thank you for taking the time to join us. From me, Jerry Gannon, and all the crew here, good night. Thanks for being with us.